A very good morning to all. I am Dr.Saramma Mathew, Associate Professor, Department of Oral Medicine and Radiology of Vinayaga Missions, Shankaracharya Dental College. Today we will be dealing about the topic that is temporomandibular joint disorders. To begin with, these are the overview of the topic. First we will be telling about the anatomy, then followed by the examination, then classification of the disorders, the etiological causes for the disorders and the investigations and the management, finally the management of such disorders in case of patients we are dealing with. What is the functional anatomy of temporomandibular joint? Where it is located? We all know that the temporomandibular joint is located between the condyle or in the position ahead superiorly of the condyle and below the glenoid fossa below the temporal bone. So, this is the position of the TMJ. What are the ligaments attached to it? There are many ligaments which will be associated with the movement of this articular disc of this TMJ. One such ligament will be the spinomandibular ligament or the stylomandibular ligaments. Along with the movement, for the movement of this disc, there are various muscles of mastication involved in this disorders. The muscles of mastications will be buccinator, the lateral pterygoid muscle, the masseter muscle, the temporalis. All these muscles play a role in the movement of TMJ. The nerve supply of this will be the cranial nerves, that is mainly the third nerve or the facial nerve. The vascular supply for this joint is ideally given by the external carotid artery. So, moving on to the movements given in this TMJ, a movement caused by this TMJ are the retrusive movement, the rotation movement, the hinge and the gliding movements. These movements are very important when pertaining to TMJ. The hinge movement and the gliding movement will help or gives the name for the TMJ as gangliomo-arthroidal joint, because it is very effective in causing the hinge movement and the gliding movement of the mandible. So, the TMJ is also known as gangliomo-arthroidal joint. This joint also helps in two other reflexes exhibited in the body, like other joints, like other knee jerk reflexes, or similar to the knee jerk reflex is called as the jaw jerk reflex when it comes to oral cavity. Also, this joint or this TMJ helps us in the opening and closing of the mouth. So, that is why although the TMJ is located in such between two bones, it is very difficult to understand the pathophysiology of the disorders and to relieve the patient from various pain. So, always the TMJ is ideally placed in the centric relation, that is at the time of closure the TMJ disc is going to be in resting position in the glenoid fossa. So, these are the pertaining to the functional anatomy of the TMJ. So, this picture will tell you where the location of the TMJ. As I said before, the TM joint is placed between the temporal bone and the superior head of the condyle. So, between these two osseous components there lies a soft tissue component called as the TM joint. So, it is surrounded by the ligaments and it is placed superiorly in front of the ear canal. So, when you take a cross section of this joint, what are the parts it is involved? So, the TM joint, when we say it is surrounded by a thin vascular supply called as thin layer of membrane called as the articular disc. So, in a cross section when we can see that the capsule is filled with synovial fluid. So, the synovial fluid is placed inside the cavities, so which makes the joint to be divided into lower joint compartment and upper joint compartments. So, in the synovial cavity, the synovial fluid is similar to the plasma, which contains the mucins, glycoproteins, and mainly it contains the hyaluronic acid. So, the synovial cavity will help in the lubrication of the disc. As such, the disc is made of fibrocartilaginous tissue and it has no vascular supply. It is this vascular supply is seen only in the periphery of the joint. So till this we have learned what is the functional anatomy, where it is located, the position of the joint and how it is supplied and what is it made of. Now moving on to the TMJ related patients, if they visit to you, what are the things or what are the steps we have to take to analyze whether the patient is having TMJ disorders. The first and foremost step what we have to do is the history taking, followed by clinical examination. So these are the few questions which we have to trigger in the patient while answering. We have to ask the questions in such a way that the patient should be able to elicit the symptoms then and there. So the first thing what we ask is if the patient has any pain. So when the pain actually started and what type of pain, whether the pain was worsening in the night or whether the pain is having any dull or throughout the day the patient is experiencing pain, or if the pain is increasing when the patient is lying down. Few other points where you have to take a note is if the pain, whether the patient is able to locate the pain or whether the pain spot triggers the adjacent area to show some pain, and also if the pain if the patient is relieving or getting any noise while opening and closing the mouth. Also we have to locate if the patient has any difficulty while opening the mouth or closing the mouth. Okay. And also we have to ask one important question, if the patient gets anxious or if the patient is facing so much stress during that time, whether the patient is experiencing pain. So all these questions will help us to, give us the clue to know if the patient is having any TMJ disorders. Moving to the clinical examination. So in the clinical examination, what are the things we have to look at? First is the inspection. So in the inspection, first is we have to locate if the patient is having any facial asymmetry. So facial asymmetry is one key feature to avoid or to delineate our diagnosis from other disorders. So first we have to think of facial asymmetry, followed by the opening pattern, like whether there is any deviation or deflection when the patient opens and closes the mouth. Then we have to see the range of mandibular movements, whether the patient is able to move freely, comfortably in the lateral position, in the retrusive position, in the protrusive position. So all the range of movements of the mandible is to be taken care in the step of inspection. So moving to palpation, once the inspectory findings we have seen, we have to go to the palpation of the main masticatory muscles, because TMJ disorders are related to the muscles of mastication. So in the step of palpation, the masticatory muscles are to be palpated, followed by the TM joints to be palpated, then lymph node in case if there is any inflammatory, to rule out if there is any inflammatory causes for causing such pain in the TM joint. So in the intraoral, these are the two findings we will see in your clinical examination. In the intraoral examination, we should also record the clenching pattern of the patient and also the teeth if there is any attrition or abrasion because due to any parafunctional habit. So all the features have to be recorded before going into the diagnosis of the temporomandibular joint disorders. So in the palpation, so as I said, the palpation of masticatory muscles are to be taken care. Okay. So the muscles to be palpated will be the, since in here we can make out that the fanning of the muscle, that temporal muscle is involved, and here mainly the masseter, and then the lateral pterygoid muscles are to be palpated in case of TM joint disorders. So in the palpation of lateral pterygoid at the buccinator, you have to make the patient half closure of the mouth, and then in the posterior aspect, the retromolar region and in the temporal region, we have to examine the muscles of mastication. Also, we have to check the clenching of the teeth. So in the intraorally, when you examine the teeth alignment, we have to check for two major errors or two major abnormalities seen in patients opening and closure of the jaw. First is the deviation, then is the deflection, which are very important to the TM joint disorders. So in case, what is deviation is, when the mandible is opening, when the mouth is open, if the mandible movement is away from the midline, that is, you can see an S-shaped or a C-shaped curvature. If the mandible is able to move away from the midline, followed which, while the closure also, the mandible goes back, takes in a deviated position and returns back to the midline, that is known as deviation. In deflection also, the mandible is moving in the lateral position, but there is no returning back to the midline. That represents the deflection of the tooth. So this opening and closing pattern of the mouth to be recorded. So whether the patient is having deviation, whether the patient is having deflection. So these 2 points to be taken care while doing intraoral examination. Moving to the next step, that is the classification. Now we have to analyze which disorder the patient, we have to group the disorder. So we have to have a basic classification. So the diagnostic classification for TMJ disorders is broadly divided into masticatory muscle disorders, TM joint disorders, chronic mandibular hypermobility, then growth disorders. So all these 4 comprises the diagnostic classification. So masticatory muscle disorders is again divided into various types. That is, either it can be protective co-contraction, local muscle soreness, myospasm, and centrally mediated myalgias. So all the muscle related problems are grouped under masticatory muscle disorders. So this TMJ, next is TM joint itself has various disorders, which we will see in the next slide. Moving to the next one is chronic mandibular hypermobility. So under which you have the, we have to classify it as the ankylosis type, which can be either fibrous or bony type. Then the muscle contracture, either myostatic or myofibrotic, and the impedance of the muscles of the condyle itself. The coronoid gets impedance, that is classified under chronic mandibular hypermobility of the associated structures related to TMJ. Following the growth disorders, we have congenital and developmental bone disorders, under which you have, there is complete absence or development of the condyle, then the partial development of the condyle, that is hypoplasia, or sometimes any cancerous growth in the condyle. So all this will be grouped under developmental bone disorders or congenital. In muscle disorders, that is congenital muscle disorders, we can be either hypertrophy or again muscle tumors like rhabdomyosarcoma or leiomyosarcoma or hypertrophy. All this can lead to, again, grouped under growth disorders. So moving to the temporomandibular joint disorders itself, it is divided into 3 categories. That is, there is a derangement between the condyle and the disc. So that is classified as derangement of the condyle disc complex. Then there is structural incompatibility of the articular surface, and then there is inflammatory disorders of the TMJ. So derangement of the condyle and disc complex is the commonest disorder which we come across mostly. So under which you can have either the disc, totally the articular disc is displaced, or the articular disc is dislocated with reduction and disc dislocation without reduction. So most of the diseases comes under these or grouped under these 2 classification. Next is the incompatibility of the articular surfaces. That is, if there is any addition, deviation in the disc itself, either it can be from the condyle or the fossa, or if there is joining of the disc to the either of the bone, that is called as addition. And then there is subluxation, that is either due to hypermobility, or there is spontaneous continuous dislocation, that is the disc, that is the mandible or the condyle moves always out of the socket, similar to the knee or shoulder dislocation. So then there is the classification about the inflammatory disorders of the TMJ, under which there are various inflammatory diseases like synovitis, retrodiscitis, arthritis like rheumatoid arthritis, osteoarthritis, So all this inflammatory component is grouped under inflammatory disorders of the TMJ. So the first classification was under muscles. So the muscles of mastication, if there is any problem, will be grouped under the category called as myofascial pain dysfunction syndrome. So myofascial pain dysfunction syndrome, or MPDS in short, represents the muscle pain. So the muscle pain can be either due to the soreness of the muscles or overactive of the muscles of mastication, or there is improper denture placement, or there is overhanging restoration. All this can cause straining of the muscles of mastication, which will lead to myospasm of the muscles or local soreness of the muscles. So that's why these are the various, it is grouped under all the pertaining to the muscles, whatever the pain or spasm or contracture is there, it is grouped under muscles of myofascial pain dysfunction syndrome. So the etiology, as I discussed before, it can be either due to the masticatory muscle spasm, that is the muscle becomes overextension because of the encroaching of the intermaxillary space, or it can be either due to dental restoration, or it can be due to either prosthetic appliances. So over contraction is usually seen in the bilateral side in the posterior teeth. That may be due to the continued resorption. If there is lack of any posterior teeth, the muscle gets has to compensate for the food overload. So then there will be resorption of the mandibular bone, and that will cause over contraction of the muscles. Then the muscle, due to which the muscle becomes fatigue, and that will lead to, due to these parafunctional habits, the muscle becomes working overload with the work overload, and then it becomes the muscle fatigue disease. So these are the few etiology which are responsible for the pain, or for these are the few reasons which are responsible for the etiological causes for the muscle related disorders of TMJ. So what are the clinical features will be seen in such muscle related complaints of TMJ? So usually the patient will be below the age of 40 years, usually the females are affected, the prevalence is seen towards the females. So how do you categorize this muscle related disease of TMJ is based on Laskin's criteria. Laskin's criteria indicates the 4 cardinal signs plus 2 negative signs. This is how the Laskin's criteria has been given. So if the patient's symptoms falls under these 4 cardinal signs and 2 negative signs, then we categorize the patients as having myofascial pain dysfunction syndrome. So what are the 4 cardinal signs seen in MPDS patients are? The patient will have unilateral pain in the muscles of mastication, followed by there is muscular tenderness, then there will be clicking or popping noise, sometimes there will be limitation of jaw movement. So out of these 4, if the patient is showing few responses, then that also indicates that it is going to be MPDS. The negative character is there is no radiographic evidence, the TM joint, the condyle is going to be absolutely normal without any tenderness in the TMJ area when we palpate in the external auditory meatus. So if there is no radiographic evidence and no tenderness in the TMJ area, with the patient is having muscular tenderness purely, then we categorize the patient to have MPDS. So what are the treatment which can be given for such MPDS patients are? First, you can motivate the patient by giving some counseling for the patient to avoid stress, to reduce the anxious nature, and then self-caring treatment is more applicable. Then followed by physical therapy, the exercise part, general mouth opening, yawning, limitation in yawning, then physical therapy like heat application or cold fomentation. So all this will help the muscle to relax, and thereby the pain can be reduced. Sometimes if the pain is too severe, we have to go for the next stage of giving intraoral appliance like splint or bite guard. Then followed by, along with these therapies, you can also prescribe medications like common analgesics and topical application of capsaicin, and some relaxation techniques can be advised to these muscle related disorders. Moving to the next disorders, that is the articular disc disorders. So under this articular disc disorders, there are three possible components, that is the condyle, the articular eminence and the disc. So if there is any complaint with these three parts, which will lead to articular disc disorders in general. So TMJ disorders is another commonest feature or commonest disorder which we elicit in most of the patients. So how does this articular disorder is clinically manifested? It will arise in three categories. So generally, if there is any complaint in the disc disorder, we term it as internal derangements or derangements of the disc. Internal derangements of the disc involves three categories, either the anterior disc displacement with reduction, anterior disc displacement without reduction and posterior disc displacement. So these are the clinical terms which we give for any patients who is having the TMJ disorder. Apart from muscle disorders, if we come for recognition of joint disorder, so these are the three terms we are supposed to categorize the disorder. So moving to the first disorder, the disc, the normal position, this first we will discuss about the anterior disc displacements, that is it can be either with reduction or without reduction. So anterior disc displacement with reduction, that is the commonest term. So how it will be represented is, so we know the disc is located in between the TMJ, that is the temporal bone and the condyle. Now what happened is, the normal jaw closure and the jaw opening pattern, the disc is supposed to be in between and the intermediate zone is between the two bones in the glenoid fossa. When the jaw is opened, the intermediate zone will be moving ahead so that there is no friction, there is easy passage of the disc and the easy opening of the mouth occurs. But in case if the patient is having disc displacement with reduction, what happens is the patient will represent clicking or popping sound while opening or sometimes in closure of the mouth. So in the rest position, the jaw is closed. So that times, because of the steepness of the condyle or there is atrophy of this articular disc, the disc will be moving ahead from the normal position while in jaw closure itself. That is the normal position for the patients with anterior disc displacement with reduction because of the steepness of the condyle. Now when the jaw is open, what happens is the articular disc has to move this far, so that leaving the posterior aspect of the disc to come forward in the normal position. So that much distance the articular disc has moved further in the jaw opening as well as in jaw closing, which will lead to clicking or popping noise. In case of disc displacement, that is with jaw locking or without reduction, is the normal position where the articular disc is supposed to be between the condyle and the temporal bone, the position is moved ahead in the resting position itself. The articular disc, the posterior zone is coming in front of the closure. So this much gap is reduced in case of disc displacement without reduction. So when the jaw opens, the whole disc is moved ahead to the articular eminence. So which will lead to difficulty in closure of the mouth and the patient will experience severe pain. So this is what happens in articular disc displacement, anterior disc displacement with reduction and without reduction. So without reduction, there is another possible term called as reciprocal click. That is, the palpation and auscultation, there will be pain as well. When the opening and closing, the patient's disc will go back and will give a clicking sound. So when the jaw is closed, if there is clicking or popping sound, is also known as, when two times, when the opening of the jaw and while closure of the jaw, if there is clicking or popping of the popping noise heard, then it is called as reciprocal click. So in without reduction, that is also known as closed lock, where there is limited lateral movements and there will be patient will experience severe pain while opening and closing of the jaw, and always there will be deviation of the jaw towards the affected site. So, when we compare between ADD, that is in short articular disc displacement, anterior disc displacement with reduction and without reduction is, in with reduction there will be clicking and popping sound, but there will not be much pain, and it can be either symptomatic or asymptomatic, but the condition will recover on its own. The time will resolve, over time the pain will resolve. But in case of without reduction is, there will be either the possible reason could be either bruxism, or sometimes the patient has experienced some micro trauma which has really given rise to ADD without reduction. So, always there is permanent lock for the patient. Sometimes the patient will not be able to open the mouth in the mornings, or sometimes if the patient opens the mouth too wide, the jaw gets locked, it will not go back to its position. So, those are the conditions we say that ADD is without reduction. Okay, and always there will be pain for such type of ADD without reduction cases. So, another term is the posterior disc displacement. Till now we were knowing about anterior disc displacement. Now another term called as posterior disc displacement is seen. So, in posterior disc displacement, what happens is the disc is already out of the socket and it is in folded position. So, there is no strength to go back to its original position. The fold or the disc cannot even go back to its normal position. So, there will be displacement of the mandible to the affected side, and there will be mouth opening, always it is in the open closure position. Next disease or disorder where we come across is the dislocation or subluxation of the jaw. So, what happens here is the condyle, which is supposed to be in articular eminence, restricted to the articular eminence, will be out of the socket. It is like the shoulder dislocated. Because there is articular disc easiness to come out of the socket, this dislocation will happen very easily. Mostly it is seen in the edentulous patients where the condyle has no restrictions or no grip. So, that times the articular disc will come out of the socket as such. So, that is called as dislocation or subluxation. So, how do you manipulate and push the condyle back to its position is, the condyle has to be moved downward and backward position in the posterior region of the mandible and then push back to the socket. So, that is the one way where dislocation of the mandible can be corrected. Also, advise the patient while yawning to not to open mouth too wide. So, these are the factors which we can help the patient to recover from dislocation, also by prescribing NSAIDs. So, the third category of classification which we read was inflammatory disorders. So, under inflammatory disorders there are various disorders, either it can be due to rheumatic arthritis, retrodiscitis, osteoarthritis, or the inflammation of the synovial fluid itself. So, that causes synovitis. So, in synovitis cases what we can do is, we can insert the needle in the TMJ region and we can withdraw few blood for biochemical analysis, thereby the hyaluronic acid can be increased. So, that will indicate that the patient is having synovitis. This is a picture which tells about the congenital deformity where the condyle and coronoid it is fused to the zygomatic bone. So, that is one area. This represents the ankylosis of the jaw. So, the inflammatory disorders are grouped under degenerative joint diseases. So, under which either the condyle can become eroded or there is formation of osteophytes or the bone deposition has been increased. All this can lead to be the possible causes for the osteoarthritis. In rheumatoid arthritis, again it will affect both the joints and both the sides of the joint, and there will be morning stiffness of the jaw. So, gout, in case of gout, again the urate crystals deposition will be seen when we take a biochemical analysis. So, other inflammatory disorders can be septic, that is from the term that is infection due to any other microorganisms which will cause inflammation around the joint. So, such microorganisms can cause trismus of the joint. So, how you correct it is by giving or removing the fluid which is depositing around the joint. So, sometimes the spondylosis or oral dyskinesia, that will itself cause inflammatory disorders which is categorized, and that will itself cause TMJ pain. So what are the investigations we can do to know the TMJ disorders is, for the bony parts to be visualized, we have to take the extraoral radiographs such as transcranial, transpharyngeal and transmaxillary views, then OPG, under which you can get a TMJ coronal views. Then we can go for CBCT and CT analysis to visualize the bony parts of the TMJ. For visualizing the soft parts, we can either go to do arthrography or the ultrasounds or MRI. So these are the few pictures, some of the few pictures where we can how the radiographs is going to appear in case of TMJ disorders. So this is a picture where you can see that the condyle has been eroded and there is deformity in the head of the condyle, which has reduced the space between the articular disc, and this is a bony component. This is a normal extraoral view. This is a CT picture which tells you again the condyle's cross-sectional view, where we can see the space between these two components where the TMJ is located. To analyze the soft parts, this is the TMJ view of taken by using an MRI, where we can appreciate the muscles of mastication, the external auditory canal, the articular disc itself is easily visible in the MRI. So then the positioning of the MRI, the articular disc, can be easily used to find out if there is any articular disc displacement with reduction or without reduction or any other internal derangement complaints. After knowing all these disorders, the positioning, the disorders, the categories of disease, the clinical symptoms experienced by the patient, how do we manage these type of temporomandibular joint disorder patients? So always the palliative treatment is the initial therapy given for either muscular problem or the TMJ complaints. So in the palliative treatment, what do we do is, you can give a topical application containing capsaicin. Then we can also give clonazepam, that is by reducing the stress, or some antipsychotic and antidepressant drugs which will soothe the anxiousness or remove the anxiousness, decrease the anxiousness in the patients, followed by NSAIDs. In severe cases, that is where there is severe pain, where we cannot manage, the patient can be given with serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. If the patient is complaining about, usually we give this tablet of medicine if the patient is having continuous bruxism habit. So the commonest drug which we prescribe is buspirone, around 5 mg can be given thrice daily based on the severity of the disorder. Followed the palliative treatment, we can also give transcutaneous electrical nerve stimulation therapy, where we give some mild electric current, and then that will relax the muscular contracture and relieves the pain. So that is one therapy where we can give, that is called as TENS therapy. Followed by the intraoral splints. So intraoral splints, this is how the picture appears, where we can give soft splints and make the patient, and along with it we can also give the habit breaking appliances, and then that will relieve the patient's pain, and this will give the occlusion stability and the pain can be relieved. The last treatment will be the surgical management of the disorders. Thank you all for patient listening.